Welcome to our live webinar titled Relapse Prevention in Patients with Severe Aplastic Anemia. Thank you for joining us today. My name is Lee Clark, patient educator, and I will be moderating the presentation today. As we get started, I would like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the webinar program today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the webinar. If you are unable to view the webinar online, you can call in to hear the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type your question in the small text box window, and when you have finished typing, just hit enter. We will do our best to get to all questions today. When asking questions, I respectfully ask that you do 2 things to help us manage all of the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. Today's specialist is Dr. Bhavisha Patel, who is a staff clinician at the National Heart, Lung, and Blood Institute located in Bethesda, Maryland. She has been at NHLBI for the last 2 years. Welcome, Dr. Patel. Thank you for joining us today.
Thank you, Lee, for the kind introduction. Good morning, everyone. As Lee mentioned, I'm Bhavisha Patel. I am a hematologist oncologist by training, and I have been working with Dr. Neil Young at the hematology branch at NIH as a staff clinician for the past 2 years, really managing the aplastic anemia clinical trials, treating patients with aplastic anemia, and also seeing several second opinions with variety of hematological conditions that are related to bone marrow failure. So today, I will talk, my objective for the talk is to primarily talk about relapse. However, it is important that we understand the background of aplastic anemia and the pathophysiology and what really causes the disease. Then we will quickly review the first-line treatments as it has impact on the relapse. Relapse will go in much more detail. We'll start with the definition, incidence, are there any predictors? And then we'll go to the management of relapse. And then lastly, what are our current efforts in preventing relapse? One other long-term complication that we often come about is clonal evolution. So we'll talk about that. So just a little background, and this may be already familiar to you, is that relapse, aplastic anemia is a rare blood disorder. It is much more common in the Eastern countries, nearly twice as much as the Western countries. It is a benign hematologic disease, but patients get very ill, almost similar to some of the malignant hematologic disease, such as leukemia. You may already be aware that the blood counts can go severely low, requiring transfusions and also supports of antibiotics. And the really mainstay clinical feature is that the bone marrow is empty. Generally, our patients tend to be younger in age. The median age is around 10 to 25 years of age. However, we do see a second increase after 60 years of age. Back in early 1900s, when this disease, there were not too many therapeutic options, and the antibiotics and the antifungal agents were not so sophisticated, it was unfortunately universally fatal. But now, aplastic anemia is treatable in most patients with either immunosuppressive treatment, which is what we do at the NIH, or transplant, or other modalities, such as supportive care as well. So there are many different causes of aplastic anemia. Now, aplastic anemia just means that you have low blood count and the bone marrow is empty. One of the most common causes that's actually transient is chemotherapy and radiation. Patients who have gone through chemotherapy and radiation probably know that their blood counts drop. Sometimes they even get a little boosting agent, but as soon as the drug is out of their system, the blood counts recover. On the other end of the spectrum, if you're looking at this table on the right side, there are some diseases that are inherited that cause bone marrow failure, such as telomere disease, Fanconi anemia. But primarily, we'll focus on what's called idiopathic or immune-mediated aplastic anemia that results in immune destruction. Next slide. And the pathology is really the same in all of these three causes, which is that the bone marrow fails to produce elements that support the cell production. Next slide. Even though the bone marrow is empty in all three of these conditions, the treatment differ. So for the chemotherapy and radiation, as I mentioned, sometimes they get supportive care and growth factors and the marrow recovers. This is generally not permanent. For the inherited marrow failures, there are some medical therapies, but in general, stem cell transplantation is the mainstay of treatment. For the immune destruction portion of it, there are two major therapies that are available. One is immunosuppressive therapy, plus or minus L-Trombopag in today's day, or hematopoietic stem cell transplantation. So let's talk about what happens to the bone marrow. So in a normal bone marrow, you have a hematopoietic stem cell, which is the mother cell, which differentiates into two major categories of cells called lymphoid and myeloid. Lymphoid cells are primarily your white blood cells that protect you against infections like viral infections and things like that. It's a barrier mechanism for your body to protect you against infection. The myeloid cells is a little bit more heterogeneous component. Neutrophils, again, have a role in infections. Platelets, as you know, prevent you from bleeding. And red blood cells is your hemoglobin that helps carry the oxygen. Next. So what happens in aplastic anemia are these T lymphocytes. It's part of the lymphoid component, one of the cells that gets activated and starts attacking, which is the immune attack, the myeloid component. And the result of that is that you have low neutrophils, low platelets, low blood cells. Next. And when we examine the bone marrow, it's striking. This is a diagnosis that is not very difficult to make once the bone marrow biopsy is performed. What we see is, so on the left is a normal bone marrow, and take my word for it that these white component are just fat cells, which is normal component of the marrow. But all of this pink material is actually different types of cells, and primarily these cells are myeloid cells. And here is a aplastic anemia bone marrow. As you could see, the structure is nearly empty. When we zoom in, what we appreciate is that the only thing that's left are lymphocytes, and those are the bad guys, if you remember. And here's the clinical presentation, as many of you may already be aware. For the neutropenia or low white blood cell counts, we generally don't worry, as your body has amazing protective mechanism above the cell count of 500. But once it goes below 500, the risk of infection increases. The risk of infections significantly increases once it goes below 200. And these are the patients we really worry about, and sometimes put them on antifungal or antiviral prophylaxis to prevent from getting bad infections. Thrombocytopenia or low platelets, again, the normal counts are above 150. And as you could see, the risk of bleeding, even when having a traumatic experience, does not increase until less than 50. And we really start worrying about patients whose platelet counts are less than 10,000. And reason being, these are the patients that may experience what's called spontaneous bleeding, meaning there's no trauma, no inciting factor, and without anything, patients bleed. The bleeds that we're really concerned about occur in the gastrointestinal tract or the brain. And generally, that's why when the number goes below 10, we recommend platelet transfusion. And lastly, hemoglobin, as I said, is a carrier of oxygen. So when that is low, patients often feel tired, short of breath. The number below which we recommend blood transfusion is less than 7. So let's talk about the newly diagnosed treatment. So a patient was just diagnosed with aplastic anemia and has not received any treatment. The treatment largely depends on the age. So for children, what we know from the literature is that if there is an option of bone marrow transplantation, that should be something that should be employed first. If for some reason a child does not have a transplantation option, normally these are patients who are only child, and they don't have a unmatched, unrelated matched donor in the registry. In those patients, we do use immunosuppressive therapy, plus or minus L-Trombopag. The story is a little different with the adults because the complications of bone marrow transplantation start becoming a major problem the older you are. So in these patients, if transplant is an option and immunosuppression is an option, it really is a discussion between a physician and a patient regarding the risk and benefit of each of these treatment options, and then making a decision together. Now, the long-term effects of bone marrow transplantations are different than the long-term effects of immunosuppressive treatment. I'm going to be focusing on the immunosuppressive treatment long-term effects, and specifically relapse, because that's unique to the immunosuppressive treatment. About 1/3 of patients do not have a response, and they lose a response to immunosuppression and have to go through the immunosuppressive treatment again, be it the same one or a different one, we'll talk more about it, or they require a bone marrow transplantation at that point. So what are the first-line approved treatment? Now that the L-Trombopag is FDA approved, generally a new diagnosis in the United States for immunosuppressive treatment would receive, for say TG, cyclosporin, and that together is the immunosuppression component of it, and then the L-Trombopag, which is a boosting agent of megakaryocytes, which give rise to platelets, but more importantly, it boosts the mother cells, the hematopoietic stem and progenitor cells. This triple regimen results in responses in about 80 to 90% of the patients who receive this regimen. And response is generally assessed at 6 months. And at 6 months, the high-dose cyclosporin is reduced to low-dose cyclosporin, and that maintenance cyclosporin is continued for another 18 months. So the total therapy, the real therapy, it's only for 6 months, but this maintenance continues for a total of 2 years if there is no relapse in between. So let's go through a case presentation to highlight what may occur. So here's a case of a 27-year-old female who was in a normal state of health, and then presented with a weak symptoms of fever, malaise, gum pain, and bleeding. When the emergency department did laboratory evaluation, they found that the hemoglobin was low, 8.4. To give you reference, the normal is around 12 to 13, and neutrophils were 100, and normal is more than 1,500, and platelets were 13, and again, the normal is more than 150. A bone marrow was correctly done with these blood work, and it was found that the marrow was empty, or another word is hypocellular, and that there was no leukemia. In any patient with pancytopenia, meaning all three blood counts are low, we always make sure that there is no leukemia before a diagnosis of aplastic anemia is established. And as I indicated, the patient received horse ATG, cyclosporin, and eltrombopag for 6 months. Next. And here is a graphic depiction of what happened to the platelets in this upper graph and neutrophils in this lower graph. So as you could see, and here are these may be too small, but take my word for it that these bunched up numbers are very low. So at the initiation of treatment, both the platelets and neutrophils were extremely low, as I mentioned. And then at 6 months, and gradually, actually even before 6 months, we started seeing a nice increase in the blood counts to the point where the patient achieved a complete response. In our trial, and the generally accepted numbers for complete responses are hemoglobin of more than 10, platelets of more than 100, and neutrophil counts of more than 1,000. So this patient met all three of these criteria, and he was called the complete response. So at this point, if you recall, cyclosporin dose goes to lower dose, eltrombopag gets stopped, and horse ATG treatment has already been completed. So the patient was actually doing quite well for about 2 to 3 months, and then slowly we started seeing that the platelets and neutrophils both started dropping. And it differs in patients as to what sort of trend they have, but in her, the trend was very quick. She went from platelet counts of above 100 very quickly to a range where she was requiring transfusion again. And ultimately, with this trend, we called her having a relapse. So we will get back to her case to see what happened, but let's talk more about the relapse. So when to call a relapse is a very difficult question, because for the initial diagnosis of aplastic anemia, there are very good criteria because the patient's blood counts are so severe. We know that if the platelet counts is less than 20, neutrophil count of less than 500, and or absolute reticulocyte count, which is a measure of hemoglobin, is less than 60, then the patient most likely has aplastic anemia. It's not so straightforward when it comes to relapse. And I'll tell you why, because the presentation may vary. So what are different scenarios we see? We see, example number one, that platelet counts are dropping very slowly. Every couple of months, they're going from 100 to 80 to 60, and then they stay at 60. Now, is that a relapse or is that a new baseline for the patient? On the other hand, just as we saw in the example that I show you, multiple blood counts drop. And they drop very quickly into a very severe range. That is a little bit easier to say, okay, the patient definitely has aplastic anemia because the blood counts are back in the severe aplastic anemia range. It's the slow trend or trend in only one blood count that makes it very difficult. And let me give you another scenario. So there are many conditions, many normal conditions that decrease cell counts even in normal people. We just don't know how low they go in normal people because we never check them. For example, a really bad viral infection. In aplastic anemia patients, we often see that even though they don't have a true relapse, their platelet counts, majority of the time it's the platelets, their platelet counts may drop, but it's transient. They may drop and they stay at a lower level for a few months and they come right back. Pregnancy causes similar situation, and a major surgery can result in similar situation. So what I want to really emphasize is that for us, a single lab value, unless it is severe range, platelets of 2, it's not very important. What's important is a trend. So we often ask patients to keep repeating their blood work so we understand at what pace the platelet or the hemoglobin is dropping, and whether or not it's achieving just a new steady state, meaning that, the platelet counts drop from 100 to 60, but it's going to stay at 60. And if you recall, the real issue with the platelets as far as the bleeding risk starts below 50. So 60 is perfectly fine. And it may not be a platelet count we really need to worry about and expose patients to treatment toxicities. So it is sometimes can get frustrating and anxiety provoking for patients just to wait to see whether they have a relapse or not. But unfortunately, this is something that's challenging and may take a few months before a firm diagnosis of relapse is made. So at NIH, all of our protocols have consistent definitions, so there is a little bit of consistency. You may find that there is variability from physician to physician or institution to institution, and even different countries practice a little differently because of all the issues that I highlighted. For our protocols, any decline in blood counts that is deemed to be significant enough and there is a clear trend that require reinitiation of treatment is called a relapse. Now, our calling of relapse has switched over time, and the reason being the primary treatment with the addition of eltrombopag is achieving much better blood counts than we had observed historically. So that gives us a little bit more room to watch the trend of the blood work before a relapse is called. So what are some ways in the past that we have tried to prevent the relapse? And one is extending the cyclosporin. So if you recall, the primary treatment with immunosuppression is stopping the cyclosporin or reducing the cyclosporin at 6 months. So back in 2003, Dr. Scheinberg, who is one of the staff clinicians just like me, along with Dr. Young, decided that perhaps extending the cyclosporin beyond the 6 months, maybe not at a high dose level as that is associated with toxicity, may reduce relapse, meaning there's some level of immunosuppression ongoing, which can prevent those bad lymphocytes from coming back and attacking the hematopoietic stem cells. And what they found was, next slide. So basically what they did was after 6 months, cyclosporin was tapered instead of completely stopped. And the results were interesting. So let me orient you to this graph. So x-axis is showing years after receiving the treatment, and the y-axis is showing percentage of patients that relapsed. This bolded line is the patients who received the cyclosporin maintenance. And this broken line is actually when patients who stopped cyclosporin at 6 months. And the interesting part was that when you go all the way out to 5 years, the rate of relapse remained the same. But what happened was the patients who had the maintenance, their relapse occurred later. So what this tells us is that there are patients who are still dependent on cyclosporin, meaning whenever that cyclosporin is taken off or the dose is reduced, they still have activity of their lymphocytes that causes the disease to come back. So what is the story of relapse with the addition of eltrombopag? Have we made a difference in relapse rates with the addition of eltrombopag? And initially, when we looked at this in 2016, which was the first analysis we did of this trial, here are the patients who did not receive that taper. They stopped the cyclosporin at 6 months. The relapse was 60%. So large majority of the patients lost the response. When they continued the low dose cyclosporin, only 15% lost response. But remember, at that time, the patients enrolled on this study was only a small number, and also the follow-up was short. Next slide. So we reanalyzed this data. This is fresh. This has not been published. It's just been presented at other meetings just now and a couple of months ago. So now we had started this trial back in 2012. So we have data of over 6 years. What we find is that even with the addition of eltrombopag, which improves the rate at the beginning, about 30% of the patients do lose the response. Interestingly, the response lost or relapse occurs when changes are made in the treatment. So shortly after 6 months, and then again after 2 years when this cyclosporin maintenance is stopped. So can we, can you go back? Back. Forward. Okay, so can we predict at the offset when we're trying to treat the patients, can we predict who will relapse? No, we have not. This has been attempted by not only our lab, but many institutions across the world. And we have really not identified what's called a biomarker. But what we know is that older patients have higher risk of relapse. So one may ask, what if my counts come back to completely normal? Does that mean my risk of relapse is low? Unfortunately not. We see relapses in even patients who have complete response, as in the example that I showed you of the patient case. So here is the graph that shows, or a table rather, that shows that, you know, if you're over 60, your risk of relapse is 3 times higher than if you were younger. So the risk of relapse really is a bigger challenge for older folks. So what happens once a patient relapses? We have several different options, and really the options are individualized to the patient. What that means is we look at the patient as a whole. What kind of response did they have initially with the initial treatment and the drugs that we used initially? What other medical issues do they have? Do they have a transplant option? What age are they? If they have a readily available transplant option and are younger, we generally recommend for them to go to bone marrow transplantation. If that is not an option, then we start deciding, okay, with which immunosuppression is a good one to start with. In general, with our new treatment standard regimen of horse ATG, cyclosporin, and eltrombopag treatment, if a patient had achieved a good response to cyclosporin, that treatment, we would reinitiate cyclosporin. If there was no response to that, we would add the eltrombopag. If there was no response to either cyclosporin or eltrombopag, we will consider another round of what's called heavy immunosuppression, which is either with ATG again, be it horse ATG or rabbit ATG, or another drug called alemtuzumab, which does ultimately the same thing, which is sort of suppressing those T lymphocytes, the bad guys. So let's go back to our case. So as I said, this lady had responded very well to the initial treatment, and she had achieved a complete response. So we elected to restart her on cyclosporin. Unfortunately, after 8 weeks of starting it, she had not responded. So then we added the eltrombopag. And amazingly, eltrombopag did bring her neutrophil counts from less than 200 to 800, which was a relief because the risk of infection significantly reduced for her. But she remained blood and platelet transfusion dependent, which, you know, is a nuisance, but can be supported for a longer period of time for a patient. The infection risk is a bigger risk. So without a complete response or response in all 3 cell lines, we decided to stop the eltrombopag and cyclosporin after giving it a good try, 4 to 6 months. And we moved on to the second treatment, alemtuzumab. Alemtuzumab is given in the hospital over 10 days, and it's extremely immunosuppressive. And the patients usually, if they're going to respond, they respond anywhere between 6 months and 12 months. So for her, we did not see a response at 6 months. So we said, why not add eltrombopag? Because eltrombopag at least did something for the neutrophils. And maybe the combination of the eltrombopag and the alemtuzumab will help all 3 cell lines. And with that regimen, luckily, the patient had, again, a complete response. So the hemoglobin went up to 15. The platelets, I'm showing 77,000 over here, but she fluctuated anywhere between 77 and 100,000. And look at the neutrophils, beautiful. 2,900. So we were really happy with these numbers because the transplant was really not an option for her. And we were really relying on the medical treatment to work. And at this time, she remains on eltrombopag, and it is slowly being titrated down, as we never want to keep a patient on a long-term treatment. So at any time when we achieve the best response, and be it with cyclosporin or eltrombopag, we start tapering those medications down very slowly. Unlike when we use these drugs for frontline treatment, when these drugs are stopped at 6 months, we do a slow taper. Here is some data. So from the trial that's ongoing with the treatment of patients with Horsetti cyclosporin eltrombopag, when the patients relapsed and we reinitiated cyclosporin, or if they did not respond to cyclosporin alone, added eltrombopag, 70% of the patients achieved a response. Half of them only required cyclosporin, and the other half had a combination of cyclosporin and eltrombopag. Some of the things that we have to consider, practical considerations, are the toxicities from these drugs. So for cyclosporin, we really worry about kidney problems, and that's why using the lowest dose possible and getting the patients off once they achieve a stable response is always our goal. It may not be achieved for some patients, and they are cyclosporin dependent. Why that is the case is still under investigation. For eltrombopag, it's a new kid on the block. It's only been studied in aplastic anemia in the frontline setting since 2012 by our group. So the long-term side effects are not entirely known, but nothing that has been obvious to us that has come to light in our 6 to 8 years of experience. Alemtuzumab, the second agent that we very commonly use, as we used in the patient case that I described, is extremely immunosuppressive. So these patients can end up on antiviral treatment and are at risk for viral infections for a long period of time. But all of this is very manageable and something that we're used to managing. So what is the ongoing research to prevent relapse? So this protocol we are actually very excited about. So in this protocol, which is currently ongoing at the NIH, we take patients who have had aplastic anemia and who have had treatment of aplastic anemia and now remain on a very low dose of cyclosporin. So these are the patients who, for some reason, cannot get off cyclosporin. They need a small dose. And when I say small dose, it's 50, 100, 200 milligrams just once a day, and have relatively stable counts. Blood counts being stable may differ from patient to patient. It may not be exactly the same number, which is okay. We take these patients, next slide, and randomize them to a new drug, but very similar to cyclosporin, called sirolimus for 3 months, or a control arm where they just stop cyclosporin. And then the patients are assessed at 3 months, 1 year, 2 years to see what's going on with their blood counts. And what we're really looking at is what is the rate of relapse in patients who have this short treatment of sirolimus for 3 months versus patients who just stop the cyclosporin. So what is our theory behind using sirolimus? So sirolimus is a drug that's similar to cyclosporin, which is that they affect the lymphocytes, the bad guys, but sirolimus works a little differently. It actually has some additive benefits that we identified from our mouse model experiments. Next slide. So in medicine, always there are some preclinical trials which give us some clue as to how medications work and how this may affect before it goes into the clinical world. Sirolimus is a little different because it's a common drug that's used in many, many other diseases, and it has a long track record of being extremely safe. So in aplastic anemia, we have a mouse model. And in this mouse model, what we saw is when sirolimus was given, there was improvement in the blood counts, the bone marrow cellularity improved, and there was increased survival of this mouse, which is all very similar to cyclosporin. But what was unique to sirolimus was that it got rid of active immune cells. So immune cells that are trying to be active again are the ones that sirolimus attacks. So anytime any activity is detected, sirolimus goes and takes care of it. And the second very, very neat thing about sirolimus is that it increases the good T cells. So there are good T cells called T regulatory cells. That is a policeman of a sort that keeps the immune system in check. And that's something that we have not observed with cyclosporin. So there are two very unique properties where we thought that in some patients, this drug may do the trick. And this is the basis of our current trial. As I mentioned, sirolimus has a long experience and track record in transplant patients where you're trying to suppress the immune system so the body doesn't reject the kidney or lung or whatever it may be. What we are using is a very small dose and a short duration. It was picked, the duration was picked based on the available data. We don't know if that's the right duration for our patient, and that's why the clinical trial. And just like cyclosporin, sirolimus has levels that needs to be monitored. And the side effects are not too many and not severe. So one of the major side effects that we have seen thus far are mouth ulcers, but extremely tolerable. There is a swish and swallow that we give along, and usually patients don't have any major issues with that. In some subjects, we have noticed increase in cholesterol and glucose, but this is again, to my knowledge, or since I've been here, we have not required or needed to start any medication to control this increase. It's been a mild increase. And then the last thing we notice is mild drop in blood counts, particularly platelets. But this is very transient, and as soon as the sirolimus is stopped, the blood counts actually recover. So what's the status? The study that I just talked about, it's about halfway accrued. Our goal is to accrue about 108 patients. We're about in the 60 range, and we're currently accruing. We just amended this protocol to decrease the bone marrow frequency, the bone marrow biopsy frequency, and also to reduce the follow-ups at the NIH. In light of the COVID pandemic, we are following patients on telemedicine. And it's really too early because the trial has not been ongoing for long enough, and we haven't enrolled more patients to know if sirolimus is beneficial, but we do have some signal that it may be. If anyone's interested, here's some information of how to contact us and what the study number is. And the clinicaltrial.gov is always a good resource to go and look at the study details. So the number is provided over here if anyone was interested in looking at it. Next slide. So that was all that I had to talk about relapse. So I will just summarize what I discussed. So relapse occurs in about 1/3 of patients who are treated with immunosuppressive regimen. Against what we hoped for, with the addition of eltrombopag, the relapse still remains a problem, which tells us that there is immune activity in some patients that's just not suppressed with the 6 months of cyclosporin. And the addition of the low-dose cyclosporin may not be doing the trick in the few patients who still have immune activity. Sirolimus is something that we are investigating to see whether it will quiet down those active cells, and it frees the patients for from the necessity of cyclosporin for a long period of time if this duration of 3 months of sirolimus worked. I'm going to move on and talk just very briefly about another long-term complication in aplastic anemia patients who are treated with immunosuppressive treatment we worry about or follow the patient and very carefully about. It's evolution to myelodysplastic syndrome or leukemia. Both of these are a cancer of a sort. It can occur in about 10 to 15% of patients who have aplastic anemia. Half of the 10 to 15% are worrisome and require prompt treatment, and generally that treatment is transplant. For this reason, we very, very importantly stress even patients who are 5 years, 10 years out of their treatment to have routine laboratory follow-up. The frequency does not have to be very high, but maybe even every 6 months to a year to really identify downward trend early. So this could be picked up early. Just like relapse, we're unable to predict and identify patients who may be who may have this complication, but we know that patients who have multiple relapses is a major risk factor, and patients who are older is another risk factor. Here is the here are all the other studies. I thought I would take the opportunity to just highlight what are the studies that are available for aplastic anemia at the NIH. So for first line treatment for brand new diagnosis of aplastic anemia, we have 2 studies ongoing. And the first one is actually very attractive because we start with the oral therapy of cyclosporin and L-trombopag while we wait for the patient to come to the clinical center, get a bone marrow, get all the evaluation in efforts to not delay treatment any further. And then we give horse ATG whenever all that workup is completed. The 2012 study is the one that I have been talking about, which is the main study that added L-trombopag to the immunosuppressive regimen. It's still ongoing. And currently what we're looking at is exactly what I described. What are the long-term complications? At what time point do they occur? And what can we learn about it? The relapse prevention is probably the most exciting study because it really addresses the issue of relapse with sirolimus. And I hope we get some positive results as we accrue more patients. And the last study is for telomere disease, which if you remember, it's one of the inherited bone marrow failure. And in patients where transplant is not an option, we're looking at danazol, which is a drug that we have looked at before and we know it works at higher doses. But to avoid the toxicities and to see whether lower doses work just as well, we have a trial ongoing. And here is our entire team. First, I would like to acknowledge all of the research participants in many trials that NIH has conducted, because without research participants, there is no research. And Dr. Young, so here's our entire group. Interestingly, and I'll point out that I am absent from this picture because when the picture was taken, I was actually very pregnant, but that's our, those are the people that make it happen. And I would like to thank AAMDS Foundation and Lee and Julie for inviting me and supporting me through this presentation. And I think I'm right on time, so I'll end here and take any questions or clarify any of the information that I've given.
Great. Oh, thank you so much, Dr. Patel. We do have a few questions. The first question is there such a thing as partial relapse? This patient is 8 months post-ATG, and only the neutrophils and platelets have slowly been dropping.
Yeah, so this is what I was trying to highlight with difficulties in relapse calling. So we don't use the term partial relapse, but certainly relapses can only occur in 1 or 2 cell lines and not in all 3. The important thing is to look at what was the best response achieved with the initial therapy and what has the trend been of the decline. If the decline continues, your hematologist or the doctor who's treating at some point will consider this a relapse. If that is the differential or that is the thought, most likely a bone marrow will be repeated to make sure there is nothing else going on. And at that point, treatment should be considered.
Thank you. This is a two-part question. So the first part is, can COVID-19 or other viruses cause relapse?
That's actually a very good question. And unfortunately, we don't have that much data, which may be a good thing. So what we know is that certainly any stress to the immune system, and that stress could be viral infection of any kind. It could be the flu, it could be herpes virus of any kind, can result in immune dysregulation. And when there is immune dysregulation, there are a very small percentage of patients who actually go on to develop a relapse. So it's absolutely possible. The good news I was saying is that we haven't heard of a lot of aplastic anemia relapses since the COVID-19 started. So I don't know if that's just the information that's not available to us, but it does not seem that it's happening at a rapid pace. So COVID-19 in particular does not increase the risk that is already there with any viruses.
Thank you. And the second part to that question is, would cyclosporine help or hinder a patient if they contracted COVID-19?
Yeah, so that's actually an excellent question as well. Also information that is not entirely known. What we do know is that with other viruses who we have studied, there has been no correlation to increased severity of viral infection when a patient is on cyclosporin. Particularly in COVID-19, we just don't have this data available. I will tell you, in our patients who remain on cyclosporin, we have not made any changes because we just don't have data that it causes severe COVID-19 symptoms if one contracted COVID-19. And the alternative of stopping and going to a relapse is probably a greater risk.
Thank you. This question is regarding cyclosporine, and the question says, will there potentially be a release of a cyclosporine tablet that does not taste so bad? And second part to that is, are there some things that patients can do to help with the taste that's so bad, or there are some things that they can do to alleviate the bad taste?
Yeah, so that's actually all the GI side effects or gastrointestinal side effects of nausea, bad taste, feeling discomfort are very common with cyclosporin. I actually don't know the formulation question. It's an old drug. I don't think anyone is developing a new formulation, so I don't think that's happening. Some of the things that our patients try and what we recommend is to take it with food, take it with juice of your choice, except grapefruit. Grapefruit interacts with cyclosporin. Or what we recommend is to take it at night, especially for patients who have nausea, because then you sleep through it. And, you know, it works with varying success rate, but those are the things that we try.
Thank you. This question comes from a patient who is 8 months post course ATG. In the past due blood test, their neutrophils and platelets have started to drop, but the hemoglobin has remained perfect. Is this normal? Is it normal for patients to experience 2 out of 3 drops in blood counts?
Yes, it's very normal. And for some reason, hemoglobin is in some patients less affected. We see this very commonly. The cell count that changes the most in our experience has been platelets, and then the second is neutrophils, and the least is hemoglobin. So it's entirely expected. And as I said, your bone marrow may just be going to a different steady state, or this is an early sign of relapse. And the only way to tell which one is occurring is just to continuously monitor for a few more weeks to months, depending on where your numbers are, obviously, under a close supervision of a hematologist, and then determining which one it really is.
Thank you. In the context of clonal evolution, does the development of PNH suggest that evolution to MDS is less likely to occur?
No. What we know with the PNH, actually, I did not address PNH at all, so good question. What we know with PNH is that the patients who have PNH, clearly PNH is an immune disease as well, just as aplastic anemia. So the patients who have PNH, they tend to have a better response to immunosuppression, but it really does not predict whether a subject is to have or not to have MDS. It's not a predictor. There are very, very few small studies that have in the past indicated it may be a predictor, but this is very controversial.
Thank you. This question comes from a patient who has been kept on a low dose of cyclosporine after 2 years. They are a slow responder. Are you seeing many doctors who are keeping patients on cyclosporine?
Yes, the practice is very a lot because there is no standard outside of clinical trial and outside of what data is available. So our practice has always been to get the patients off cyclosporin, and generally that's at 2-year time point. Now, this patient would be an ideal patient for an evaluation to see if cyclosporin can be stopped. And, the blood counts would be monitored. And in that situation, if the blood counts drop again, the cyclosporin is reinitiated. And it would be a good patient to be considered for a trial such as ours that I described.
Thank you. This patient relapsed after 2 years of immunosuppression and went on L-Traumapag, and they've been on that for the past 6 months. If they were to relapse again, would it be suggested to try treatment again or look at a transplant?
So several things play into a factor. If a subject is young, has transplant options, does not have a lot of medical issues otherwise, a transplantation should definitely be considered, and a discussion with a transplant doctor should be taken, and then a discussion of what alternative immunosuppressive therapy are available, and a decision needs to be made after that. But yes, a transplantation should be considered.
Thank you. This question comes from an adult patient now. However, they were diagnosed at age 16 years ago. Has there been any updated research on the risk of relapse for patients who are planning to become pregnant? This patient was treated with immunosuppressive therapy.
So this is a very good question. So as I had mentioned, there are several things that causes immune dysregulation or a heightened immune response, and pregnancy is one of them. Obviously, there have been no randomized trial because studying or doing any clinical trial in pregnant women is very difficult for the reasons you may understand, may not be safe. So what we know is mostly anecdotal. And what we know is about, I would say 1/3, 1/3, 1/3. 1/3 of the patients may relapse. 1/3 of the patients may have decreased counts during pregnancy, but not low enough. And then once they deliver, counts go normal. And 1/3 of the patients have no effect on their blood counts at all. Generally, For our patients who are in clinical trial, we ask them to refrain from becoming pregnant for the first 5 years. And after, if their blood counts are completely normal, we, leave the decision up to the patient with the information that, we don't know exact number of patients that may relapse, but the risk generally is lower if your blood counts are normal and the farther you are from the diagnosis and the treatment. But again, this is all anecdotal data. There is no robust clinical trial to answer this question. And I don't think there ever will be because of the issues with studying pregnant patients.
Thank you. This question says, you mentioned risk of relapse increases for patients over 60. This patient was diagnosed last year at age 62, responded to immunosuppressive treatment well, and is currently considered in remission. Does my risk of relapse increase as I get older?
No. What we know is that there is twofold increase in risk, okay? Not definitely that you will relapse or not relapse. Two to threefold increase, but it does not increase with the age. When we analyzed our data, it's category based, so it's more than 60, 40 to 60. So your risk does not keep increasing as the older you are. We don't have that information, and it's not correlated.
Thank you. This comes from a patient who was in one of the first ATG cyclosporine trial groups. They had relapsed over the next 10 years, achieved remission in 2001. They continue to come to NIH for follow-ups and have had a growing clone population. Does the clone expansion mean that I am more prone to develop MDS or leukemia?
That's a very good question. So I didn't go too much into the detail about clonal evolution because this was primarily a relapse talk, but it really depends on what the clone is, because there are some clones where we know from our experience that really nothing happens. We just see that clone expand in some patients and stop at some point. In some patients, it actually goes away completely. In some patients, it stays the same. So it really would depend on what clonal population it is.
There's additional information. They say they have a high clone count and being over the age of 60. Will this make them more likely to relapse?
Relapse or evolution?
It says, make me more likely to relapse.
No, the fact that the subject has been had not had a relapse and had been sort of in remission of aplastic anemia for this long, that in itself actually dictates that that your risk of relapse is actually lower than if you were in your first 5 years of treatment period.
And they said, please say hi to Dr. Young and Olga.
I will.
Okay. Our next question is, what are your thoughts of an older patient who's had good numbers after 2 years, but they're still on a low dose of cyclosporine, potentially going back to teaching during the time of this pandemic, going back to the classroom?
Oh, I think it's fine. We actually have not recommended, based on the available data, any different precautions to take than general population if you're on low dose cyclosporine. It is not a heavy suppressive agent, but you would still want to follow CDC guidelines and take all the regular precautions.
Thank you. Do we know if severe aplastic anemia patients have a greater risk of death if they were to contract COVID-19, whether they are in remission or not?
No, we don't have that information. And as I alluded to earlier, we have not heard, and we have a large group of patients that we have treated over years, that there have been any major complications related to COVID-19. But take that information as it comes, because this is something that's not available to us.
Thank you. For a patient with aplastic anemia, do we know if there's been any success with people taking high doses of vitamin C or D?
No, I actually am not aware of any major studies showing impact of particular vitamins. What we do know is having a balanced diet and staying as active as possible certainly would help.
Thank you. Is there a particular dose of cyclosporine that you would recommend for somebody who wants to take additional precautions regarding COVID? I don't, I'm not
I would
exactly
not,
sure.
I would not
Yeah.
recommend any cyclosporin dose for COVID prevention. Yes, no.
And what are your feelings about patients with aplastic anemia, severe aplastic anemia, exercising, or should they not?
So the only limitation to exercising is heavy lifting if the platelet counts are below 50. Otherwise, whatever you're comfortable with and your body can tolerate, you can continue to exercise.
Thank you. This patient has been using breathing treatments while they have been taking, as an aplastic anemia patient. What are your thoughts on the need for breathing treatments while taking cyclosporine?
Are you, I'm imagining this is referring to pentamidine?
Yes.
Okay, yeah.
Yep.
So pentamidine is a prophylaxis against a specific type of infection called pneumocystis pneumonia, PCP for short. And we generally recommend this when patients are on high doses of immunosuppression. So if that's the case, then you're on appropriate treatment.
Thank you so much. Thank you so much, Dr. Patel, for taking the time today to share your expertise with us regarding this very important topic for aplastic anemia patients and their families. If you would like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If we were not able to answer your question today, you can send it to us anytime in 3 ways. Please send an email to help@aamds.org. Call our helpline at 800-747-2820, extension 2, or submit your question on our Facebook page at any time. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. The Aplastic Anemia and MDS International Foundation Medical Advisory Board and team are here to help you and your family as we have done for the past 36 years. This concludes today's program. Thank you.
Thank you.